Very good evening. I'll be talking on lens-induced glaucomas. So based on the mechanism, lens-induced glaucomas can be classified into open angle and angle closure glaucomas. In the open angle group, the important ones are phacolytic glaucoma, lens particle glaucoma, and phacoantigenic glaucoma. In the angle closure group, we have phacomorphic glaucoma and glaucomas associated with ectopia lentis. So coming to phacolytic glaucoma, as the lens ages, there will be stretching of the lens capsule and accumulation of high molecular weight lens proteins in the cortex. And these lens proteins will leak through the intact capsule, through the microscopic openings in the intact capsule of the mature cataract, and these lens proteins either directly obstruct the trabecular meshwork as in soluble lens protein theory, or get engulfed by macrophages and cause trabecular meshwork obstruction and cause glaucoma. This is a visual microscopic picture which is showing a liquefied cortex and wrinkled capsule with a Morganian cataract. So the clinical presentation, the patient will give a history of progressive diminution of vision since months or years prior to the presentation, and they present with acute painful eye, and they drop in whatever vision they have. So sometimes they will have headache and vomiting. If the intraocular pressure is very high, there will be associated photophobia. There will not be any history of trauma in these cases, and patient will present with low diminution of vision. On examination, there will be conjunctival congestion. Depending on the intraocular pressure, there can be epithelial edema. Anterior chamber will be deep in these cases, and you can see the lens matter in the AC, and it's known as pseudohypopyon. There will be a raised intraocular pressure. You can see a mature cataract. Gonioscopy may not be possible, but the angles should be open. There won't be any KPs on the endothelium. So what all differentials you have to keep in mind? One is acute angle closure glaucoma, where you have a shallow anterior chamber depth. In uveitic glaucoma, you will have other signs and features of uveitis like KPs and all. In neovascular glaucoma, you will be able to see the new vessels. If it is chronic, you may be able to see the ectropyon UVA and sometimes hyphema. And traumatic glaucoma, madam has already explained. So coming to the management, initial management is you have to control the inflammation and intraocular pressure, for which you have to give topical steroids, topical cycloplegics and anti-glaucoma medications. You might have to give systemic anti-glaucoma medications also. Cataract extraction is the definitive treatment. It may be plus or minus IOL. You may end up in putting a CTR also. Combined surgery should be planned if it is long standing. That is the onset of symptom to the surgery. If it is more than 3 weeks, you may need to plan a combined cataract with trabeculectomy. For cataracts extraction, SICS may be a safe option. Coming to lens particle glaucoma, here there will be a disruption of the lens capsule. It may occur after a cataract surgery or penetrating lens injury, and this will lead to release of the lens particle into the anterior chamber, and this lens material is toxic, and this exposed lens material will cause inflammation, and they can lead to aqueous outflow obstruction. Patient will have may present weeks or months or years after the precipitating event, will give the history of surgery or trauma. Patient will present with almost same as in phacolytic glaucoma, like acute pain, diminution of vision, redness. On examination, there will be conjunctival congestion, epithelial edema, anterior chamber, there will be cells flare, and you will be able to see the cortical lens matter in the anterior chamber. Intraocular pressure will be elevated. There can be peripheral anterior synechiae or posterior synechiae, angles usually open. Again, the initial management is the same, control of inflammation and intraocular pressure. Maybe you have to look carefully for the residual lens matter. Sometimes the lens matter can be present in the tunnel of the cataract surgery, or sometimes it may be in the angle, so careful gonio is very important. And if the lens particle or the material does not get resorbed, or if it is a large amount of the lens particle in the anterior chamber and the intraocular pressure is not getting controlled with the medical management, you may have to do a surgical removal of the residual lens matter. Coming to phaco-antigenic glaucoma, it is an Arthus type immune complex reaction which is mediated by IgG and the complement system. So there will be history of a trauma or surgery which lead to disruption of the lens capsule, and these lens proteins are exposed to circulation and they are recognized as foreign by the immune system. So this will initiate a granulomatous inflammatory reaction directed against own lens antigens, and this will lead to obstruction of the trabecular meshwork and increased intraocular pressure. Again, there will be a latent period of 1 to 14 days between the lens protein exposure and onset of inflammation, and the clinical findings, again, it includes circumcorneal congestion. There can be KPs on the endothelium, moderate cells and flare with hypopyon. Sometimes this hypopyon may be blood tinged, and this will give a clue that is a phacoanaphylactic glaucoma. You can see the residual lens material in the AC synechiae formation. Sometimes there will be low grade vitritis also. Intraocular pressure will be elevated and it will be open angles. The management is same, initial management is same, and if medical treatment is unsuccessful, here also you have to do a surgical removal of the residual lens material once the inflammation is under control. Next, in the angle closure group, you have phacomorphic glaucoma. So mature cataract can lead to forward movement of the lens iris diaphragm. It can lead to an irido-lenticular contact or a direct irido-trabecular contact, and it can present as a chronic angle closure or sometimes present as an acute angle closure. This can be either appositional or synechial. So the clinical presentation, again, patient will have a decreased vision. It can be reduced to up to hand movements or PL. In acute cases, there will be lid edema, circumcorneal congestion, corneal edema, shallow anterior chamber with cells flare, peripheral anterior synechiae might be there. In the acute case, again, there will be mid-dilated fixed pupil, and you will be able to see the intumescent mature cataract, raised IOP, and the angles will be closed. You have to do a gonioscopy for the fellow eye to rule out occludable angles. If it is a chronic angle closure, you may not get the signs and symptoms of the acute attack, but the pressure will be very high with closed angles. So the first picture is an acute attack, and the second one is a chronic angle closure, phacomorphic glaucoma. So the differentials you have to consider is primary angle closure disease and secondary angle closure, which may be due to choroidal lesion or effusion. Maybe you have to rule out a plateau iris, iris or ciliary body cyst, and ectopia lentis. Management, reduce the intraocular pressure and control of inflammation as the first line, and once you control the IOP and inflammation to some extent, LPI should be tried, and later you may end up in doing a cataract surgery. Parasympathomimetic agents should be used with caution since they can precipitate pupillary block. In the fellow eye, you have to do a prophylactic PI if it is occludable angle. If the IOP is not getting controlled with the medication and after LPA and it is very high, you might need a combined surgery. Shorter the duration between the onset of symptoms and surgery, the better prognosis of visual acuity. Next is glaucoma associated with ectopia lentis. There will be a history of trauma or associated with systemic disease which can lead to anterior subluxation or dislocation of the lens, which in turn lead to pupillary block and angle closure. So the first picture was a patient with history of trauma who presented with acute onset of symptoms, and on examination the part of the lens was in the AC and a pupillary block, mid-dilated fixed pupil. So we gave mannitol and tried to reduce the pressure to some extent and did a PI. So with one shot I could open up the, get an opening, and I just re-examined after an hour. The second picture is showing the lens position after an hour. Lens has gone back, and it was behind the iris, and it was like subluxated inferiorly. So by next day it went into the vitreous, and then the retina surgeon took it out. So the next picture is, it's again a traumatic case, and there was anterior subluxation of the lens, but it was still in the pupillary plane. So the management, if there is anterior subluxation but there is no pupillary block and good vision, do a conservative management and monitor the intraocular pressure. If there is anterior subluxation and pupillary block with good vision, do an LPI alone. If there is complete dislocation into the anterior chamber or vitreous, removal of the lens is the definitive management. So to conclude, lens particle glaucoma and phaco-anaphylactic glaucoma need removal of the residual lens matter. In phacomorphic and phacolytic glaucoma or dislocated lens, you need a lens extraction. The surgery can be challenging because there can be a low endothelial cell count, shallow AC, small pupil, brittle capsule, rhexis extension, zonular weakness. Dislocated lens may need sometime limited anterior vitrectomy. Laser iridotomy will relieve the pupillary block prior to the surgery. Thank you.